All right. Good morning, everyone. So today I'll be talking about a topic of more structural flavor. Why isn't TMVR TAVI yet? My objectives for today is to go through some clinical considerations and indications for TMVR, or transcatheter mitral valve replacement, pre-procedural evaluation and screening failures, and finally, some issues around valve design and future directions. So I want to start off with a case. Some of you might know this case. This is a 61-year-old lady who was referred to us with NYHA class 3 symptoms, multiple frequent hospitalizations with acute decompensated heart failure. And in one of her admissions, she actually required some milrinone to go over that, acute phase. She has a history of coronary artery disease with PCI to the LAD and RCA in the setting of a STEMI a few years back. Her EF was 41%, and that's after optimization with medical and device therapy. Prior to that, it was severely reduced. AFib, had a CRTD implanted as part of the heart failure optimization, and her other medical issues are listed on the right side. So this is her echocardiographic evaluation, which showed a dilated LV and an EF that's mildly reduced. The RV was deemed to have normal size and systolic function. This is her screening TE, and she has essentially both leaflets are apically tented with restricted posterior leaflet and anterior override, as you can see here, with significant posteriorly directed mitral regurgitation. The important points here is that her valve area was less than 4, so 3.75, and she had a baseline mean gradient of 3 millimeters of mercury at a heart rate of 82 beats per minute. So we discussed her on our usual Monday rounds. Based on her clinical scenario, we feel that she's of high surgical risk, and given her symptoms related to severe mitral regurgitation, despite medical therapy, we feel that she's a candidate for edge-to-edge repair. So we take her to the cath lab, and keep in mind she had a small valve area and an existing gradient at baseline. So we tried initially an XTW clip, which is kind of our initial clip typically in someone who has a sufficient posterior leaflet length, and she had a mean gradient of, with that of about 11. So we couldn't leave it in. So keep in mind, these patients are on general anesthesia when these clips are put in. So we often feel that the mean gradient would typically go up by a couple of points if you do an echo the next day. So we just remove the clip, and then we try an XT. And it gives us a mean gradient of 7, which is still not acceptable because, again, 7 means probably when the patient's not under GA, probably her mean gradient is going to be around 9. So we didn't feel that this was appropriate, and an NT clip also gave us a similar value. All of these clips were successful in reducing MR, but the residual gradient was a little bit too high. Despite optimal medical therapy that's with ongoing, fine-tuning by the heart failure service, she continues to be symptomatic. So we discuss again whether she's a candidate for another transcatheter modality. And we think about transcatheter mitral valve replacement. So the valve that was available to us at the time was the Tendyne mitral bioprosthesis through the Summit trial. So this is a transapical device that's fully retrievable, fully repositionable, with no need of cardiopulmonary bypass. And we feel that it's reasonable to evaluate her for that device. And it's the early feasibility study for this device with 2 years follow-up data shows almost complete obliteration of mitral regurgitation, if you look at the graph here down on the left side, with significant improvement in NYHA functional capacity up to the kind of 2-year mark of follow-up. And if you look at the right side here, you can see that there's a significant reduction in hospitalizations for heart failure. But despite all of this, there is a significant mortality of 27% at 1 year and 41.6% at 2 years, which, if anything, to me, tells us that maybe we still have an issue with patient selection. Despite procedural success and despite symptomatic improvement, we still have higher mortality at 2 years of follow-up. Just tells you that we're treating very, very sick patients, and we may not be selecting these patients properly. This is an example for a patient that underwent a Tendyne TMVR here at St. Michael's Hospital, and you can see basically what the valve looks like on TEE immediately post-implantation. So as part of the evaluation for TMVR, we sent the patient for a CT scan. And what a CT scan does, it sizes the mitral valve annulus, it looks at the landing zone and the subvalvular apparatus, as well as it evaluates the extracardiac structure, the adequacy of the transapical axis, and the risk of neo-LVOT obstruction. So if you look here on the right side, the LVOT, as you know, is formed by the interventricular septum, as well as the anterior mitral valve leaflet. So when you implant a device, depending on the design of the device, but not only that, also on the anatomy of the patient, the length of the anterior mitral valve leaflet, whether there's a bulge or not, you may run into the risk of neo-LVOT obstruction. And what CT scan evaluation does is that it evaluates for that. This is an example of a pre-TMVR CT. And if you can see here on the top left image, some of the things that they look at when we do these CTs is the intertrigonal distance here with the blue arrow, the intercommissural distance, as well as the septal lateral distance, and these measurements help us size the valve. There's also the aortomitral angle. In this particular patient, it's 135 degrees, but the more acute the angle is, the higher risk of LVOT obstruction. The length of the anterior mitral valve leaflet, the extent of MAC, the height, the maximum height of MAC, the maximum thickness of MAC, as well as we typically use a virtual model of the TMVR device. And here on the short axis, you get to see the neo-LVOT. And what they do is they simply trace it to assess for the risk of LVOT obstruction after device implantation. So LVOT obstruction is an important complication of TMVR. It's potentially fatal if it happens acutely. If you look at the picture here on the right side, this is a patient post-TMVR implantation, not here, but I found this online. And you can see that the anterior mitral valve leaflet is really protruding into the LVOT. This patient had significant LVOT obstruction. You can see that also in the transthoracic picture here. And you can see the tracings over here. So it's the LVOT obstruction in general is reported in 7 to 9% of cases. And a lot of people say that this number has likely dropped significantly, given that companies and clinicians are becoming good in screening these patients for LVOT obstruction. It has two types. So you get acute LVOT obstruction, which happens immediately after you implant the valve, and this is kind of potentially more fatal. And then you can also get chronic LVOT obstruction, which happens after your LV remodels. After TMVR implantation. The definition that we use for LVOT obstruction is an increase in the peak gradient of more than 10 millimeters of mercury, or you have a peak gradient above 30, and it's considered hemodynamically significant if it's above 50. And the risk of LVOT obstruction based on the neo-LVOT measurement, so patients with 1.7 to 1.9 centimeters squared, anything less than that is considered very high risk. In real life, though, 2.5 is the number that we use, that I've seen used more commonly. If you have less than 2.5 centimeters squared of neo-LVOT, this is when people start to kind of worry, would this patient be at an increased risk of LVOT obstruction? But this is what's published in the literature. So who's at risk for LVOT obstruction? People with small ventricles, asymmetric septal hypertrophy, a more acute aortomitral angle, as we've discussed. So perfect. So what I was saying is that there's different ways to mitigate the risk of LVOT obstruction. Here at St. Michael's Hospital, we use alcohol septal ablation mainly. And what we do is we select a coronary artery that supplies, that's very proximal, supplies the interventricular septum, and we use definity contrast. Actually, it's a transthoracic guided study, and you can see that there's an enhancement to the basal septum right here.
And what we want to make sure is that there's no further enhancement anywhere in the heart or the RV wall. And we can see that it's kind of, in this particular patient, it's isolated to the basal septum. And once that's confirmed, and also what we want to confirm is that the enhancement is at the site where we see flow acceleration on baseline echo. We distill alcohol, which results in a controlled chemical injury to the basal septum. So in this particular patient, we had a reduction in the peak gradient from 145 millimeters of mercury down to 20 millimeters of mercury, which can facilitate TMVR in some patients. So the limitations of this particular intervention is that it increases the risk of pacemaker implantation. You really have to wait for some time for the remodeling. So usually there are 3 phases. Immediately after the procedure, you get the wall motion abnormality. So you get an improvement in your gradient. But after that, there's an inflammatory phase, and which can increase the thickness of that portion of the septum again. So you can have an increased gradient temporarily before you go back into atrophy, and you get the more permanent picture of what your LVOT gradient would look like. The other challenge is that you really have to find an appropriate vessel, and some patients with very small septal vessels, you were unable to perform the procedure. So the other option would be the LAMPOON procedure. So it stands for the laceration of the anterior mitral valve leaflet to prevent outflow obstruction. And it can be done in a retrograde fashion. So they would basically insert 2 catheters into the heart, electrify a wire to pierce the anterior mitral valve leaflet, which is snared and pulled backwards to lacerate the mitral valve. It can be also done in an antegrade fashion. The problems that are associated with this particular procedure is that it's not feasible for calcified leaflets. You can't really puncture it with the wire. It may not completely resolve your LVOT obstruction. And once you do it, you create torrential MR. So you're stuck. You really have to do the TMVR. And if you're unable to do it, you put yourself in a situation of a surgical emergency. The other option is the scorpion procedure. So this is a procedure that I learned about in TVT just in the past few days. This has been done in one center that has been able to publish their experience of 6 patients between 2018 and 2020. And what they do is that they radio frequency ablate the basal septum with 2 catheters. The problem is that all 6 patients required pacemaker implantation, and it only resulted in a modest improvement in their LVOT gradient and their septal wall thickness. The other option is the sesame procedure. And what they do is similar to the LAMPOON. They would insert 2 catheters into the heart, and basically they would engage with the basal septum with a wire, and they basically go through the basal septum with that wire before re-entering the LV cavity. And then that wire is snared with a second catheter. And if you can imagine, you would be slicing open that basal septum, as you can see in the picture right here, and therefore reducing the risk of LVOT obstruction. This particular paper is an animal model of 5 pigs who underwent this procedure. 2 had a VSD as a result of it. When I was at TVT, one of the presenters actually went through a case of a sesame procedure in his particular center, so it was actually performed in humans before. One important point before I move on is that you don't really have to have LVOT obstruction when you do these procedures. You need to have a high risk of LVOT obstruction with TMVR, which basically in a patient with a sufficient septal thickness may allow you to do these procedures to mitigate the risk of LVOT obstruction with TMVR. In our particular patient that I presented earlier, there was no particular risk of LVOT obstruction per se. So the neo-LVOT, as you can see here, has adequate parameters. The only problem is that for us to be able to implant the valve, you had to go through a very posterior or extremely posterior axis. So the procedure was not feasible because of the inadequacy of the apical axis of the device. So the second thing that I wanted to talk about is screening failures. This is a frustrating issue for both the patient and the clinician, and it often relates to patient-related factors, factors related to the underlying anatomy and the design of the valve. At the moment, the screening failure rates are extremely high, more than 50%. So if you have a patient that you want to send for TMVR, you're at least, you have a 50% chance of a screening failure. And most often this is related to an annulus that's too large or too small, as well as a high risk of LVOT obstruction. And the early feasibility studies have failed mostly to report on screening failure rates, which puts the whole valve design thing at a challenge because we are unable to inform future designs of the valve. But we think that this problem will eventually improve as new TMVR systems tend to be developed with more sizes and lower profiles to reduce the risk of LVOT obstruction. So for our particular patient, we initially did not know what to do as we didn't have any further TMVR valve options, but eventually we had one and we wanted to try a different approach, a transfemoral approach as opposed to a transapical approach. So one possible option is to try the Intrepid valve developed by Medtronic. This is their early feasibility study of 14 patients, and you can see that in this particular valve, they were able to obliterate mitral regurgitation with early data showing improvement in NYHA functional capacity with zero risk of mortality, stroke, re-intervention, or pacemaker implantation. The problem is the device currently is not available in Canada, and this is still true today. But the device that was available to us at the time was the Edwards M3 valves through the Encircle trial. So this valve basically is designed with the concept of a valve and ring procedure. So you have a dock, and the dock has a leading turn that basically grasps the subvalvular apparatus of the mitral valve, and then two additional docks, and then there's an atrial portion that has a PVL guard and an atrial arm. The valve that's implanted is identical to the SAPIEN 3 number 29 valve, except that it's completely covered externally, which allows a good seal between the device and the docking system and reduces the risk of PVL. This is what the device would look like after deployment. And the early feasibility study of the M3 valve showed excellent technical success of up to 90%, no 30-day mortality or stroke, and the median hospital admission after the procedure is only 1.5 days. And there's almost, again, complete obliteration of the MR with improvement in NYHA functional capacity. So in our particular patient, we took her to the cath lab, and the videos, I don't think they're longer, they are working because I switched to a Windows computer, but essentially we crossed the interatrial septum with the delivery catheter. And then after that, what we do is we would advance the docking system, as you can see here, and then we would lower the docking system and advance it towards the medial commissure of the mitral valve. And this is one of the things about this device is that you need to have a healthy medial commissure. You can't really have a diseased medial commissure, as this is where the dock will be advanced into the left ventricle. And you can see here, once the device is under the mitral valve, we would advance the leading turn. So we'll go to the next slide. And you can see here, okay, so these videos are working. In this procedure, we explain from the long axis, and over here you see a bicommissural view. So over here, you would have a medial side of the mitral valve, and this is the lateral side, and you can see that there is this white bright dot under the medial commissure over here. And then in the lower picture, you see 2 dots under the medial commissure and 1 dot under the lateral commissure, indicating that the first turn or the leading turn of the docking system is complete. After that, a few seconds after, once you have the leading turn done and you've cleared the LVOT, a few seconds later, you would have the second and third turn. Typically, they go smoothly as long as you have had a successful first turn. This is a transgastric view, short axis below the valve, and you can see this is the docking system now with all 3 turns complete, and you can see the entire subvalvular apparatus is within the docking system. And over here with the X-plane, you can see posterior, anterior, lateral, medial all have 3 dots under them, again indicating a successful deployment of the docking system under the valve. And then the final stage is to deploy the atrial part, and you can see here this is the mitral valve, this is the aortic valve, this is the left atrium, and you can see the PVL guard, the balloon-like structure over here, and the arm of the docking system over there. So the docking system was deployed, then we advance the valve through the docking system, and it becomes a valve and ring procedure. The valve is inflated into position with a balloon. So this is after the procedure. You can see that there is successful deployment of the mitral valve. And you can see down here that there's no residual MR or paravalvular leak. This is the 2D pictures over here as well. This is what it looks like down here on fluoroscopy. And then in 1 month follow-up after the procedure, you can see that the valve is well seated and is functioning normally. The patient had NYHA, enjoying an NYHA functional capacity. She was euvolemic on exam. The EF is still mildly reduced. And she feels great. And actually, we saw her this past Monday in clinic, and she continues to do extremely well. So comparing a transapical versus a transfemoral system, they have comparable success rates of up to 95%. They have similar rates of conversion to surgery, mortality at 30 days, and LVOT obstruction. They're slightly more moderate to severe MR with the transfemoral devices, but all of these devices are still in their early experience. And I think as the design improves and as the experience of the implanters improves, we would have less of these issues. So can one size fit all? So can we have a group or a single device that can fit all patients? So this is data from the Choice MI registry, and it looked at about 750 patients who were referred for TMVR. And of those 750 patients, only 30% actually successfully screened for the procedure. And 70% did not. So some of the characteristics of those who did screen failed for the procedure is that they had a smaller LV, they had more primary mitral regurgitation, and they had more significant MAC. So how did we get into this situation? So how can we develop it? How is it possible that we develop a device that only works in about a third of the patient? Well, if you look at the early experience of the device, initially it was developed for patients for functional mitral regurgitation. The reason is that these are the patients that are typically rejected for surgery. These are the patients who are typically sicker and at a higher risk with lower ejection fractions. So all the companies initially were geared towards developing devices for that specific patient population. So this meant developing devices that are for large annuli and large LV cavities, which meant that you need to develop larger TMVR valves that required larger delivery system as a result. And therefore, we had more transapical access devices in the earlier phase of developing TMVR. But as we were able to implant and offer these devices to more and more patients, we ran into issues with patients with aberrant septal anatomy, septal bulging, for example, patients with severe MAC, issues with the subvalvular apparatus whether it's a high papillary muscle, mitral annular disjunction, bulging of the LV wall, some sort of interaction with another device like a TAVI. And going back to the choice MI registry, among those 70% of patients who were, screened failed for TMVR, about a third actually were unable to proceed with any further intervention, whether it's a bailout clip or high-risk surgery. So up to a third, which is a big number of patients, were their only option was medical therapy, which again is a frustrating issue both for the patient and the implanter. And we've went through this briefly, but again, the most common cause of screen failures are annular size, again, too big, too small, risk of LVOT obstruction, and then you get small LVs, MAC, leaflet morphology, severely reduced LV function, amongst other things. So different devices have different delivery as well as anchoring mechanisms, as well as different exclusion criteria. So we can't really generalize a particular exclusion criteria because each device has its own way of being deployed and implanted. And I can't really go through each different design parameter and exclusion criteria, but what I want to focus on is down here on the right, is that what we need is an adaptable septal puncture system, reduce the risk of LVT obstruction, at-risk patients with mitral annular calcification and severe LV dysfunction. And septal puncture, a lot of people are biased and think it's a minor part of the procedure, and I think they're biased by the successes of the valve in ring and the valve in MAC. You basically introduce the valve, you make sure that it's in the right position, and then you would just inflate the balloon. But right now, the TMVR systems are extremely sophisticated. You really need to be coaxial onto the native valve of the patient, and this is looked into with a lot of detail using the pre-TMVR CT. The anatomy of the IVC as well as the right atrium is taken into account. They would give you typically before the procedure a particular height that you would want to puncture into the left atrium and then they would also estimate the primary and the secondary flex in order for you to achieve that coaxial alignment of your TMVR system with the patient valve. And oftentimes that's easier said than done and is extremely difficult. And unfortunately, we are at a stage right now where we are adapting the patient's anatomy to the delivery system, and we still don't really have a delivery system that's more adaptable to more complex anatomy. But we definitely need to work on that before have more penetration of the device and to be able to deliver to more patients. LVOT obstruction, we already covered this in a lot of detail, but I wanted to say here that not all factors are modifiable. So modifying the design of the device may not entirely resolve this problem, as you may have non-modifiable factors. In addition to patient's anatomy, you may have some, for example, interaction with another device like a TAVI, which does increase your risk of LVT obstruction. The other thing is MAC. Even though MAC is common, I feel that this problem has been completely neglected by device designers, and I don't really have a good explanation why. But the problem with MAC is that you can have a device deformation after deployment, and when you have a deformed device, you have reduced life expectancy of the device and its function. So the mechanics of the device get affected, and you have more or higher risk of structural valvular degeneration. So one of the things that we have to address is that we need to make devices that are resilient to MAC, that they're able to function under normal and real-world mechanics and anatomy to have a more durable solution for these patients who are typically quite complicated. So can one device or one size fit all? Maybe in the future, but unfortunately right now we are not there yet. But hopefully this will improve over time. We need to work on improving our transfemoral delivery system and make sure that it's adaptable to the patient's anatomy. Trying to cherry pick patients to adapt to the design of the device is definitely more challenging and is a significant barrier with offering these devices to our patients. The devices need to maintain their mechanical performance in real-world anatomy, and I'm referring here to MAC. We need to develop lower profile devices that don't have a lot of depth to reduce the risk of LVOT obstruction. And finally, our imaging, both the protocol and the technology, needs to evolve to better plan for TMVR and to guide these procedures successfully. So that's everything that I had for you guys today, and I really apologize for the technical issues. Not sure what happened with the internet this morning. Happy to answer.
Certainly. So thank you. Very comprehensive review and bringing what you learned from TCT, I guess. So question.
Yeah.
So I noticed that in the history of development of these devices, especially in the story of the TAVI, it was actually Canada who was actually doing a lot of work ahead of US. So I remember actually meeting with Stephen Nissen at some point at Cleveland Clinic, and he was saying, well, you know, we actually can learn a lot from your Canadian guys because we were doing TAVI at least 2 years ahead of them because of the regulatory environment. How do you see the Canadian regulatory environment right now helping Canada as a country to actually be ahead? So do you see any observation in TCT that, you know, we're actually ahead, that we can do things that Americans are still sort of like looking to do because of the FDA requirements?
Yes, so that's a great question. And I think that overall, centers like St. Michael's Hospital or St. Paul's in Vancouver is doing well with offering these cutting edge, you know, technology to patients. And definitely in these conferences, again, our centers and mostly Vancouver, but some other centers are fairly visible as amongst the leaders in providing this technology and sharing their experience with other implanters. Some of the challenges that we have is that I'm not sure if it's the current supply chains with COVID or what exactly is the problem. Is we don't really have, some of the companies don't really want to leave the United States to come to Canada. One good example for that is ICE or 3D ICE, which is commonly used in the United States for implanting tricuspid devices and tricuspid edge-to-edge repair. And we're still having difficulty bringing this technology to Canada. When I was having my conversation with the reps of the company in ASC, their issue was device availability, and this may be related to the supply chain issue created by COVID, but also the availability of a trained workforce, people who can actually come and proctor us and train us to use these devices. So these are the major challenges, but I think that over time these challenges will be resolved as you know, the technology and the chip problem and the supply chain problem gets resolved, and these companies have the, you know, the appropriate workforce to come and help us implant, use these devices and implant these devices. The same issue with the Intrepid device from Medtronic. They don't have enough workforce, and therefore and they have enough business in the US, so less incentive to come and offer devices, this device, particular device, to Canadian patients. So hopefully over time, as these companies overcome their workforce issues, we hopefully will be able to offer these devices to our patients. In terms of government regulation, the main issue that I hear about sometimes from these company reps is the need for paperwork to come into Canada. So these reps often, if it's their first time, need to apply for, you know, paperwork and visa to come and work in Canada. This can be somewhat of a barrier, but I think it's a minor barrier. Yeah, I can't really say that I'm an expert with all the regulations that would impede these companies from having a device implanted in Canadian patients. But this is just what I learned from my, you know, personal conversations with some of these reps.
Yep. It gives our country a very unique position actually to leapfrog the United States, because I think from a device point of view, it's easier to get approval to at least start in person or in human use than United States. But on the other hand, imaging, because the market is so much bigger, that they would actually get all the approvals in the States first, like such as the 3D or 2D eyes and 3D eyes way back when. And then, you know, in Canada, typically, whatever they have down there, like we've seen, like with string and like Tomtech stuff and 3D eyes, things like that. It takes about 9 months to 18 months before they, like we see in ASC, and then we will see it here.
Yeah.
So typically we see that there's a bit of a tale of a two city.
Exactly.
So Qiming, it's Bob.
Yeah, go ahead.
A question for Ines. It just, and you probably partially answered it, but the process for like the first case, the first time you use a device, presuming you're not going to the animal lab to do this, you're actually doing it on a patient. So what's the like? How does that work, given that you've not done one before?
Well, my understanding of how this works is essentially we would screen a patient. So all of these patients need a TEE and a CT, and we send it to the company, and the company processes these images, and they determine, based on the patient's anatomy in their core lab, whether the patient is anatomically suitable for this procedure or not. A lot of the early feasibility studies are non-randomized studies, meaning that if a patient is accepted, they would get the device. After that, a date is set and the company would come. Typically, they plan 1 or 2 days of training for both the implanters and the imagers. So they would typically go through, for example, a PowerPoint where they would go through the important points and the important parameters that we have to look at echocardiographically during the procedure, before, during, and after. They would bring in some their own expertise, so some experts and proctors who are very, well versed with the procedure, and they guide us through the imaging process. For example, in our case, throughout the evaluation and then eventually implantation of the device, and then the post-evaluation of a patient. The same thing happens with the on the angiographer side. So they bring in models and different devices that are used to train the implanters and they have some experts that would come over that would really guide and train whoever's implanting the device throughout the procedure. That's basically it. And obviously, you try your best to choose a patient who is, perfect for the device, where you won't anticipate any issues during the procedure. And in most cases where I've been there, whether it's the Tendyne valve or the M3 valve, it's been, fairly successful so far. And the more experienced your implanter is, in our particular case here at St. Mike's, we have, excellent people, Dr. Pham, Dr. Bagay, and the rest of the team. They're really well versed. So once you really understand and imagine the 3D dimension of the LA and how these catheter interact with the patient and the imaging, they tend to do kind of relatively well with any device that they implant, just because they have this know-how, and all devices somehow follow kind of similar rules and similar mechanics. So this is how it's essentially done, and this is how I've seen it happen with the M3 and the Tendyne valve.